we have a really exciting talk tonight, and I'll be sharing some interesting information with you, some of which you've never heard before. It might think it sounds pretty crazy, but we will have some time for questions afterwards, so just sit back and relax. I just threw this up here just so you knew that I wasn't just some bum off the street coming to talk about some lunatic procedure. I am trained in medicine and obstetrics, and have previous research publications in pediatric leukemia, cannabinoid receptor research, and abortion pill reversal. I also, at the beginning of my talks, like to make sure that everyone knows I have no financial gains from this. The progesterone industry is not lining my pockets with lots of money to push progesterone. So we always want to make that clear. So I want to tell you a story of how this all started. In 2006, we had a practice that was full-range family practice, inpatient, outpatient obstetrics. And I got a call one day while I was in office from the crisis pregnancy center that a young lady, 19-year-old, had taken the abortion pill down in Charlotte, immediately regretted it, and wanted some help. Wanted to know if there's anything she could do. She actually went back to the abortion clinic. They said there's nothing you could do. If you don't go through with the abortion, then the baby, if it survives at all, will be deformed, will be mentally delayed. They used all kinds of scare tactics, and they said, and if the baby does die, it will remain inside of you, and you'll get an infection, and you could die. So she's very terrified about what to do. So she called the local, actually she told her mother, they called the local crisis pregnancy center, who I was working with at the time in Cabarrus County, and I told them to send her right over. So she came over, told me the story about how she had kind of been coerced into becoming more intimate with her boyfriend, and he had promised to take care of her and her baby, but once she got pregnant, he said, no, get an abortion. So, of course, it is like getting punched in the gut, and she did not want to do this, but she started the process, and here she was 36 hours later, having taken the abortion pill, not knowing what to do. So I told her I really needed to, step out of the room, think about it, and as I did that and prayed about what to do, I started thinking about how RU46 works. So mifepristone is a progesterone blocker, and it blocks the receptor at where the placenta is, and this essentially shrivels up the blood supply to the baby, and the baby starves, and the placenta sloughs off just like in a woman's normal menstrual cycle, where a woman is withdrawing progesterone, progesterone is leaving her body, and she goes into a normal menstrual cycle. The lining of her uterus sloughs off, and she has a menstrual cycle. Well, RU46 is very similar. It tricks the mother's body into thinking essentially she's having a menstrual cycle. It blocks the progesterone receptor. The body doesn't think it's getting progesterone, and the placenta breaks away from the uterus, and essentially the baby dies. And then the second pill, which is taken 24 to 48 hours later, is then a pill that stimulates contractions, and she goes into labor at home, and then has essentially a toilet abortion, okay? And that's kind of what you saw in the movie Unplanned. And women can bleed from that for hours or days. So, this is not, something they teach us in medical school, how to fix this type of thing. In fact, they normally teach us, if anything goes wrong in the first 9 to 10 weeks of pregnancy, there's nothing you can do, no matter what the problem is. So I got the idea that if the RU46, which blocks progesterone, could be kind of outcompeted if we put extra progesterone into her system, maybe we could throw enough good chemical in there to outcompete the bad chemical, and we could activate the receptors and restore the pregnancy. So it's very important how quickly this happens, because the younger the baby is, and the longer that you delay in trying to block the bad chemical, the more likely you are to have a successful abortion. So I went in there and told her, I said, listen, we do fertility treatments with progesterone in our office because my partner, Danny Holland, had gone to Pope Paul VI Institute, had done the NAPRO fertility training, was certified counselor there. And we had progesterone in the office. I said, listen, if we give you a shot of progesterone, we might be able to out-compete at the receptor site and nullify the effects of RU46. I said, this hasn't been done. It could kind of delay an inevitable abortion. Progesterone has been known to be safe in use in fertility treatments, even when women are pregnant. And so I felt confident that this was not a safety issue. So I said, listen, there's no guarantee, but this is probably our only chance. And she was very, very desperate. And she said, listen, I would really like to try this. I understand that there's a risk, but I think this is our only chance. So we gave her first injection of progesterone, and she left the office, and I said, come back. This was on a Friday. Well, that night, she actually started bleeding. She called my partner who was on call, who told her to go to the emergency room. And she went to the emergency room, and thankfully she did not get an ER doctor who is heavily pro-choice, because most of them would say, well, let me call OBGYN and they'll just do a D&C right now. Instead, they did an ultrasound, and she got to see a heartbeat. And she was so excited just to see that heartbeat. She said later, if that's all that had happened, it would have been worth it. So she got to see the heartbeat, and the doctor said, go home and hope for the best. So she went home, and thankfully, by the next day, the bleeding had stopped. She came into our office on Monday, and we confirmed the heartbeat again. So we kept giving her progesterone shots twice a week during the first trimester. And we kept an eye on the ultrasound of the baby, and the baby developed well and normally. And at 40 weeks, Kaylee was born perfectly healthy. This picture is about 4 years ago, so she's now 12 and doing well in school and very active in her community and very thankful. And interestingly, her mother, who had been kind of threatened by the boyfriend that she'll get kicked out of the home and won't ever make it in school, she ended up completing her training as a respiratory therapist, and now she's saving babies at the neonatal center down in Charlotte, so they've done very well. So let's talk a little bit about abortion, the abortion pill, and also the reversal, okay?
My name is Dr. Anthony Levatino. I'm a practicing obstetrician gynecologist, and I performed over 1,200 abortions. Today I'm going to describe a first trimester medical abortion. This is a procedure in which the mother swallows pills in order to terminate her baby, and it is performed up to the 10th week of pregnancy. The procedure involves 2 steps. Step 1. At the abortion clinic or doctor's office, the woman takes pills which contain mifepristone, also called RU46. RU46 blocks the action of a hormone called progesterone. Progesterone is naturally produced in the mother's body to stabilize the lining of the uterus. When RU46 blocks progesterone, the lining of the mother's uterus breaks down, cutting off blood and nourishment to the baby, who then dies inside the mother's womb. It is important to note that even after it has been taken, it is possible to reverse the effects of RU46 and save the baby if progesterone is administered. The sooner, the better. Step 2. 24 to 48 hours after taking RU46, the woman takes misoprostol, also called Cytotec, that is administered either orally or vaginally. RU46 and misoprostol together cause severe cramping, contractions, and often heavy bleeding to force the dead baby out of the woman's uterus. The process can be very intense and painful, and the bleeding and contractions can last from a few hours to several days. While she could lose her baby anytime and anywhere during this process, the woman will often sit on a toilet as she prepares to expel the child, which she will then flush. She may even see her dead baby within the pregnancy sac. At 9 weeks, for example, the baby will be almost an inch long, and if she looks carefully, she might be able to count the fingers and toes. After she has disposed of her baby, the woman may have bleeding and spotting for several weeks. Bleeding lasts, on average, 9 9 to 16 days. 8% of women bleed more than 30 days, and 1% require hospitalization because of heavy bleeding. The failure rate increases as the pregnancy progresses. If failure occurs, she will usually be offered a surgical abortion. For the mother, medical abortion often causes abdominal pain, nausea, vomiting, diarrhea, headache, and heavy bleeding. Maternal deaths have occurred, most frequently due to infection and undiagnosed ectopic pregnancy. As I mentioned at the beginning, I'm Dr. Anthony Levatino, and in the early part of my career as an OBGYN, I performed over 1,200 abortions. One day, after completing one of those abortions, I looked at the remains of a preborn child whose life I had ended, and all I could see was someone's son or daughter. I came to realize that killing a baby at any stage of pregnancy for any reason is wrong. I want you to know today, no matter where you're at or what you've done, you can change. Make a decision today to protect the preborn. Thank you for your time. I will no longer do any more abortions. When you finally figure out that killing a baby that big for money is wrong, that it doesn't take you too long to figure out it doesn't matter if the baby is this big or this big or this big or maybe even this big, it's all the same. And I haven't done any since then, and I never will.
Okay, so just to review, so the medical abortion is 200 milligrams of mifepristone or RE46. It's taken up to 10 weeks pregnancy or 70 days after LMP. That's a recent change in the FDA approval. It was approved in 2016. Before then, it was only up to 49 days. 24 to 48 hours later, 800 micrograms of misoprostol is taken orally or vaginally to induce contractions. The patient passes fetus and products of conception into the toilet. Bleeding can last 6 to 30 days. Retained products of conception can lead to infection or hemorrhaging. And the effectiveness of the two-pill process is 94 to 98% in patients that are less than 8 weeks pregnant. Very, very deadly combination. So I just want to throw this slide in here just to show you how prevalent the medical abortions are becoming. Most of us grew up in a time where we didn't have medical abortions. We thought more of abortions as a surgical procedure. But you can see with the medical abortions versus the surgical abortions that the medical ones are getting more and more, and the surgical ones are becoming less and less. And this is only 2013. These numbers are essentially even now in 2019. So getting close to half of all abortions before 9 weeks are done by medical abortion or the abortion pill. So let's talk a little bit about progesterone and how it works. Progesterone prepares the endometrium for implantation of the embryo. It promotes the decidual development or the placental component. It inhibits myometrial contractions or labor, promotes growth of breast milk producing cells, and inhibits milk production, and it keeps the cervix closed. So women that have a lack of progesterone for whatever reason often have early miscarriages, and this was why we used it for fertility treatments. And this is just a little cartoon showing where these progesterone receptors are along what's called the decidual basalis. And when those are activated by progesterone, it promotes growth of blood vessels and supports the fetal development. Mifepristone is a progesterone antagonist. It blocks the progesterone receptor at the placenta and uterus interface, or the decidua. It binds to progesterone receptor twice as well as natural progesterone. Mifepristone has a half-life of 18 to 25 hours, while progesterone half-life is 25 to 55 hours. So really, once a woman takes RE46, in the first day, about half of it's gone. In the next 24 hours, another half of that is gone. So if a woman can get past 3 to 4 days after she's taken the RE46, then most of it's out of her system and not doing anything anymore. So those first 3 or 4 days are really important. to be able to get in there and block the effects of it. The rates of incomplete abortion with 2-drug regimens were 5% before 7 weeks and 7 to 8% at 50 to 63 days. So in other words, very effective. You can see that the younger the fetus is, the more likely it is to die. And if the fetus is older, getting up close to 10 weeks, this is 9 weeks, then you have a little bit better chance of survival. But this is something that's going to come up later. Incomplete abortion means the uterus did not completely empty. That doesn't necessarily mean that the fetus survived, okay? Rates of surviving embryo with the 2-drug regimen were less than 1% before 49 days and 9% if given at 57 to 63. So these are survival statistics. So before 7 weeks, less than 1%, and up to 9% with 2-drug regimen if up to 9 weeks pregnancy. But with mifepristone alone, in other words, just the abortion pill and not the labor-inducing pill, completed abortion was only 60 to 80%. So that means that in many cases, when people are taking both the RE46 abortion pill plus the labor pill, they're actually have never maybe really even killed the fetus. They're just essentially having labor, essentially having like a forced miscarriage of a live embryo. So here's the idea about abortion pill reversal. We give progesterone 200 milligrams intramuscular as soon as possible after the ingestion of the abortion pill. Then we perform a transvaginal or transabdominal ultrasound as soon as possible to confirm embryonic or fetal viability, make sure that we can see a heartbeat. We don't want to delay the administration of progesterone if ultrasonography is not available immediately. We've gotten into that sometimes with some of our providers. They're very caught up in trying to make sure that the baby's still alive and worth saving, so to speak. But that time is really important, and that can take hours or even days to get to an ultrasound. So we encourage people to give them that first injection or first dose of progesterone and then worry about getting an ultrasound. If less than 6.5 weeks after the last menstrual period, some doctors will monitor the HCG levels to make sure that the levels are going up. But this, I always caution people to monitor these very carefully, because a single HCG level on its own doesn't mean a whole lot. You have to see a pattern to compare them, okay? So then we repeat progesterone, 200 milligrams intramuscular every day for 2 more days. So the first 3 days of the treatment, they get a shot every day. And then every other day until day 14 after the ingestion of RE46. And then we treat with progesterone 200 milligrams twice a week until the end of the first trimester. So most of the patients, the most important part is hitting the system hard in the first 72 hours. And after 72 to 96 hours, most of that RE46 is going to be out of the system. And then we keep supplementing the mother with progesterone. And often we will also check progesterone levels so that if she's producing enough on her own, then she won't need the treatments anymore. So we have progesterone also that's compounded into vaginal suppositories, and these are alternative treatments. Now we've come across alternative treatments, and this is kind of how real medicine and real research works. You might have patients who either don't have access to injectable progesterone, or they're so afraid of needles they won't take a shot, and the shots don't feel very good. And so we've had some patients who said, no, I won't do it, but I'll take another form of progesterone. So some of the doctors started using vaginal suppositories of 400 milligrams, and they take it every night until the end of the first trimester. There were some women who were taking prometrium, 200 milligram oral capsules, 2 capsules vaginal each night until the end of the first trimester, and some of them were swallowing them, okay, 400 milligrams orally each night, or some would take them one pill twice a day until they'd take 2 capsules twice a day until the end of the first trimester, so 400 milligrams twice a day. And that was orally. Of course, you gotta, obviously, when you take a pill orally, you gotta think about what's happening in the stomach, the acid, what it's doing to the chemical, to your medicine, and also it has to go by the liver, and the liver is gonna take out a lot of your medicine too. So that's why the doses are different. So if we see the progesterone receptor as a lock and the progesterone as a key, you got to think of it as the progesterone attaching to the receptor, and it successfully unlocks the door or unlocks the lock. Whereas mifepristone is like a key that doesn't unlock the lock. It just gets in the way and sits in the receptor site. So I'm going to play this. This doesn't have any sound. But this gives you an idea of what an antagonist and an agonist do. So an agonist fits into a receptor, and it fully activates that receptor or channel, or makes the machine go, okay? And so an agonist would be progesterone. Now, there's such a thing as a partial agonist, and we're not dealing with that in this case, but that's a chemical that can go in and partially activate the receptor and get the desired effect, okay? And then the third type is an antagonist, and RU46 is an antagonist. It fits into the receptor, but it doesn't do anything. And not only does that, but it blocks the other agonists from getting in there. Okay, so progesterone can't work in that case. Okay, so if we take that same example, this would be progesterone. That's the lining of the uterus. And these are the receptors. And the keys will activate those receptors and unlock the door so that all the good things that progesterone will do will happen. Increased blood supply and growth of the uterine lining and supporting the pregnancy. If you have RU46 plus progesterone, you throw a bunch of these fake progesterones in there, and they will fit into these locks, but they won't turn them. You might get one here and maybe one here that will activate from progesterone, but overall, you're not going to get a good effect. And then if you have the RU46 and you throw in a bunch of extra good keys, then you can activate a bunch of those receptors and you can support the pregnancy. And so this is really the result. This is a picture of a lot of the babies that have been born and some happy mamas and daddies. So to date, there have been over 600 babies born healthy, with over 150 mothers still pregnant and going through the protocol. No major side effects or birth defects, and we've had reversals performed in 48 states and 14 countries. So we've had some opposition to abortion pill reversal. There's a lot of pro-culture of death folks out there that want to squash this. And these are kind of their main complaints. They want to consider this unproven or junk science, that the treatment is no more effective than if you just do nothing. There are no controlled studies proving its effectiveness. They complain that it's not FDA approved, that it's not endorsed by experts in obstetrics, that it's not available for women to get treatment. Many don't believe that women change their mind in a significant number. They also complain that they don't know if it's safe for women, and if babies survive, they will be born with birth defects. So let's address some of those. First of all, junk science. A lot of physicians who are just working in offices really have never done research. They've never had to come up with a hypothesis, a testable hypothesis, and never had to actually make experimental methods and perform experiments and then publish the research. So you have to make sure that you have, in order to have a good scientific basis, you have to make sure that you have a couple of things. First, the science has to make logical sense. And we kind of discussed the logic behind abortion pill reversal. Then there should be some animal models that demonstrate the science that makes logical sense. Then there are usually case studies that demonstrate that there might be a possible treatment. And then retrospective case studies with larger numbers to show whether or not this is truly effective on a large scale. And then after that, there's usually controlled trials with various protocols to show what the optimal efficacy is. So we talked about the logic behind RE46 reversal and that it makes sense with the locks and the keys. Then as far as an animal model goes, there's a Japanese study where pregnant rats were given either RE46, mifepristone, or mifepristone plus progesterone. The group that was given only mifepristone had only 33% survival of pups. The group that was given mifepristone plus progesterone had 100% survival of pups. Other effects of mifepristone on the endometrium, or the lining of the uterus, were not seen in the group that also received progesterone. So they actually dissected the rats and looked at the lining of the uterus, and there was no damage that would have been done by the RE46 if the rat also received progesterone. So we have a solid animal model that demonstrates it can work. So in 2012, actually late 2011, I was contacted by Dr. George Delgado and Mary Davenport. George Delgado is a physician in San Diego, and he had gotten a call 2 years after my reversal where someone had asked him, can an abortion be reversed? And he had never even heard of my process, so it's really interesting that he came to the same conclusion without any influence from my work. And he came up with the same idea because he had gone to Pope Paul VI Institute and also had progesterone in his office. And so he also helped manage an abortion reversal, and his patient survived. So he said, look, maybe other doctors are doing this, and he started looking around and he saw that there were. And so he published in the Annals of Pharmacotherapy in 2012 the first case study that had 6 women that had all taken RE46 and then sought out reversal. All were treated with 200 milligrams of intramuscular progesterone. One patient had first gotten treatment with vaginal progesterone, but then she took the shots. 4 of these women birthed healthy babies. 2 fetuses did not survive. 66% success rate with progesterone treatment among these 6 women. Opposition kept saying, well, this is just a small little number, and we don't know if this really affects, this could just be a fluke. And they're right, it's not a powerful study, and it's not meant to be. This is just a case study of small sample size to see if there might be something worth investigating. And of course, that's why in 2006, when I had my reversal, I didn't, go screaming from the mountaintops, hey, this is the best thing since sliced bread, because we really still didn't know, is it a fluke, or are we really doing something? So over the years, as we started collecting data and having more providers, we got together and in 2018 published this next case series detailing the successful reversals of the effects of mifepristone using progesterone. And this was published in Issues in Law and Medicine. This was 754 women who decided to attempt reversal, and they were screened for inclusion in a retrospective study. A retrospective study means that it's already happened and you're looking back on it, okay? You're not planning out ahead of time what's going to happen. In other words, you're not going to have some women impregnated and then give them an abortion pill and then give them a reversal or a sugar pill. You're going to look back and see what the women chose to do and then pull out from that any significant data. So 547 women met criteria for inclusion in the study. Others were lost to follow-up, or they decided to proceed with an abortion, and therefore they were not included in the study because they weren't following the protocols. They were essentially having an abortion, or we just lost track of them. In this large study of over 547 women, that were in the study, the overall reversal rate was 48%, but groups that used the injectable progesterone exclusively or high-dose oral progesterone to completion had very high success rates of 64% and 68% respectively. So then the opposition started saying, well, that's no better than if you just did nothing. And that's what normally doctors would do. If a woman came to them and say, well, just don't do anything and hope for the best. And so the opponents were claiming up to 50% failed abortion if mifepristone is given, but then misoprostol was not given. And so there were some studies where they had this term failed abortion or incomplete abortion as their result. But their definition of failed abortion or incomplete abortion is that the mother failed to empty her uterus. So that doesn't mean that all of those fetuses were still living. Some were dead, but just hadn't passed out. So a failed abortion does not equal a living fetus. And there have really not been any definitive studies as to exactly how many fetuses will survive if you don't give that second pill. So Dr. Mary Davenport and myself and Dr. Delgado did a literature review, and we looked at thousands and thousands of pieces of research literature regarding RE46, progesterone supplementation, but mainly failed abortions in the setting of abortion pill. So this is what we found. Mifepristone is an effective embryonidal agent, but it's not effective at emptying the uterus of its contents. Misoprostol was added to more effectively empty the uterus, and we've already talked about that in their protocol. Confirmed embryonic survival by ultrasound ranged from 7 to 25%, with doses of 200 milligram to 600 milligram of RE46 at gestations less than 7 weeks, and with 400 to 800 milligrams of RE46 at gestations up to 70 days. So what we're saying there is, even though they were claiming, oh, well, 50% of women will have an incomplete abortion, really, at the very best, the studies show maybe a 25% where the embryo actually survives, which is very, very different than our results. So the high numbers of abortion failures are related really to the incomplete emptying of uterus, not to the babies surviving. So many of the failed abortions did kill the fetus, they just stayed inside the uterus. The actual highest percentage of surviving fetuses after mifepristone alone is about 23%, which is much lower than the survival of 67% in our studies. So then they started complaining, oh, well, this isn't an FDA-approved treatment. Well, many current accepted treatments, especially in pregnancy, do not have FDA approval because nobody wants to risk trials on pregnant babies. One thing, a baby is precious and you don't want to be messing around with possibly hurting a baby or the mother. But also, researchers are notoriously scared because they can essentially be sued for that baby's entire life. The baby gets to 18 years old and, is cross-eyed, and they're going to come back and try to sue this researcher. So no one wants to do pregnancy-related research. Progesterone is FDA approved for the treatment of pregnant women at risk for preterm labor and birth, and is deemed safe and effective. Mifepristone was FDA approved for use in the U.S. in the year 2000 at 600 milligrams and up to 49 days of pregnancy. This is what kills me, kind of in the hypocrisy of the people that are complaining that we're using a non-FDA approved treatment. FDA approved RE46 at 600 milligrams up to 49 days of pregnancy, but soon after that they found that 600 milligrams was quite a bit more expensive than 200 milligrams, and it also had more side effects. So the abortionists got it down to 200 milligrams, and they started using it up to 10 weeks pregnant. But they were doing that for years. It was off-label, not FDA approved. And it was only in 2016 that the FDA, under great pressure from the abortion lobby, changed the label. So they were essentially using it off-label for years and years. So then they complained, well, this isn't endorsed by experts. And if you talk to the American College of Obstetrics and Gynecologists, the ACOG group, of course, who are very kind of pro-abortion, they say it's hogwash. But we do have the endorsement of the American Academy or Association of Pro-Life Obstetricians and Gynecologists, and it's over 2,500 providers and associates in that group. We've also had some unusual endorsements by some pro-choice doctors and scientists. Pro-choice Dr. Harvey Kleiman, the head of fetal medicine at Yale School of Medicine, admitted in a reporter's story in an interview that if his daughter were pregnant and was exposed to mifepristone, someone tried to poison her or get rid of the baby, that he would give her progesterone to try to combat that. Daniel Grossman, who has been in many interviews on CNN and downplaying our research, and he's at University of California, San Francisco, admitted that it does make biological sense. To this day, we've grown to over 800 providers that are physicians and physician extenders that support the protocol and can deliver it to mothers that want to reverse their abortions. So it seems like we've got a pretty good group of experts that endorse this. Safety is number one in our minds for the mothers and the babies. And so we don't want to downplay whether or not the treatment is safe. So we did research on this. In 1999, the FDA review concluded there's no risk of birth defects, including hypospadias, which is where, like on a little boy's penis, the hole, instead of being at the end, is kind of underneath and he pees downwards, okay? But that was one of the concerns, that there would be increase in that. But including hypospadias, there's no increased risk of birth defects in pregnant women taking progesterone or 17-hydroxyprogesterone. Long-term adverse consequences of progesterone therapy have not been identified in humans and appear unlikely. This is in the American Society of Reproductive Medicine in 1981. And Dr. Thomas Hilgers, who's done about 30 years of progesterone research, has shown less risk of hypospadias and side effects in progesterone-exposed fetuses versus those without progesterone treatments. There's also no increased risk of birth defects in babies exposed to RE46, the abortion pill, if they survive it. So it either kills the baby or it does nothing to the baby. There's a 5% increased risk of something called Moebius Syndrome in babies that have been exposed to the labor-inducing pills, Cytotec or misoprostol. That's a syndrome where they can have weakness in facial muscle tone, facial nerve palsy, the ability to control eye movements. They have weak limbs. Some of them may have a syringomyelia called mermaid syndrome, where their legs are kind of grown together. But remember, this is only if the baby is exposed to Cytotec, okay? And our protocol calls for treatment with progesterone after the abortion pill, but before Cytotec. We certainly don't recommend any woman taking the Cytotec. It has a high risk of birth defects. We also know that women do change their mind. Most studies show about 10% of women surveyed have second thoughts or ambivalence. Many women are pressured or coerced into abortion. And then the good question is, if people are pro-choice, well, why would they deny a woman's choice to attempt to save her baby? And why deny them a second chance when they do change their mind? Our protocol is not forced on anyone. And we know that women change their mind because our hotline is getting over 200 mission-critical phone calls per month, meaning women that call up and express a desire to reverse their abortion. So, how does this whole system work? How do women get into the system? So yes, we do have cute kids right outside of the abortion clinic holding signs. And women can come out and get a card or a pamphlet with the information on it, and they can call that hotline number. There are billboards up around the country promoting this and letting people know about it. And this is a picture of our ultrasound unit that from Health Crisis Pregnancy Center in Monroe. And this is Tara and the team that mans that unit. And we can now offer abortion pill reversal right on that unit, right outside of the abortion clinic. So the woman comes there, and we've had several so far, I think 2 or 3, that have come right to the bus there. And then we follow up with them in the clinic the next day. And one night, actually, Courtney took the bus. It was about 11 o'clock at night, and went to someone's house and did an ultrasound and started abortion reversal at about 11 o'clock at night. So these guys are real troopers, never tire of helping women. And the Crisis Pregnancy Center, the Pregnancy Resource Centers, are real heroes in this. They serve as a hub for connecting the mothers with the doctors. The hotline also points folks to the Pregnancy Resource Center, and they will identify a provider that's close to them. So about 1.5 years ago, we were managing the whole hotline, and we had 24-hour coverage with a small group of people. Heartbeat International now staffs the 24-hour hotline for mothers seeking reversal. And what's amazing is that Heartbeat International is in 62 countries, and they have over 2,500 pregnancy center associations. So that really spreads this protocol availability. Of course, we have abortion pill reversal website and mobile platforms. We have very smart computer people that know a lot more about cookies and things like that than I do. And so if a woman is at the abortion clinic or something, and she searches abortion, how can I reverse my abortion? But then she changes her mind. Later she's looking at the internet and it pops back up. Something about saving her baby, or abortion pill reversal keeps coming up back onto her screen. And so it kind of, she starts thinking, wow, God must be telling me something. I need to reverse this abortion. So we have some really great technicians that have done that. Women are then screened when they call the hotline to see who's eligible for reversal. Some women call for diapers. I mean, it happens when you have a hotline. And we refer them to an appropriate service for that. So once we identify the women that are eligible for reversal, a provider is located as geographically as close as possible to the patient, and they are called. Now, we would love to have this protocol available in emergency rooms. And there are some emergency rooms that have talked about putting it in, but they're still very nervous about the newness of this protocol. But I definitely see that in the future. And I've even heard of a couple of abortionists who have done reversals, have given progesterone. Then an appointment is made for evaluation, and possible progesterone treatment is made. And then the patient is followed up by the reversal provider or their own OBGYN. So, for instance, in our case, we might start a reversal for the first 3 days, and then we turn it over to an OBGYN that they know that they're going to do their follow-up with. And remember, the first 3 to 4 days is the most important time. And then, a few years ago, we were getting a lot of questions about how can we get this in our clinic. And so we designed this emergency abortion pill reverse kit. And this has everything in it that a clinic might need. You open it up, and it has, we put syringes and medicine in here. And then we also have all the protocols and the data information, gathering information that is sent back to us so that we can collect information. And then we also have instructions right on the box. So it's just a quick way to have it in the clinic where they can pull it off the shelf. The pills, if people use the pills, they actually have a pretty good shelf life. The injectable only has about a 3-month shelf life, and the suppositories only about a 3-month shelf life. But if you have pills, they're good for at least 6 months. And they're not very expensive either. So we had we went to the National Press Conference, and we had a big press release where we were introducing this reversal kit. Interestingly, now we're having legislation that's being written and passed to ensure mothers know that reversal is available. As a doctor, I hate the government telling me how to practice medicine. Really, I want them out of it. The problem is that women were getting bad information. They were getting information that was dangerous for them and dangerous for the babies they were wanting to save. So informed consent laws have been going up around the country. State representatives are introducing bills that require abortionists to inform women that receive the abortion pill that they may be able to reverse the process if they change their minds. And usually this is written information, and they also have to have it on their websites with the 1-800 number or the 877, the toll-free number. So there's actually 8 states that have enacted legislation: Arizona, Arkansas, Idaho, Kentucky, North Dakota, Oklahoma, South Dakota, and Utah. All have informed consent laws that say that a woman has to be made aware that if she changes her mind, she might be able to seek treatment and reversal. And then there's more states that are currently voting on bills that would give mothers this important legislation, including Ohio and North Carolina. And just a couple weeks ago, I was down in Raleigh at a pro-life rally where we gave a talk about this to try to, and I met with some legislators to encourage them to get behind this legislation. And now Mike Conway, the Republican in Texas, has introduced a federal bill at the beginning of April, the Second Chance at Life Act in Washington, that would essentially be an informed consent law for women on the federal level. I'll try to repeat your question. Yes.
I have a question. Why do you choose 200 milligrams of progesterone? I mean, is it too dangerous to give more than that, but more than that, like, be more protective?
Yeah, well, you would think that higher levels of progesterone, you can have more side effects because progesterone does increase the risk of clots and other problems. We have more of a problem with that with synthetic progesterones. Prometrium that we use is a bioidentical hormone, and the 17-hydroxyprogesterone is the bioidentical injectable progesterone that we use, and with less side effects of clots and the other problems that come with progesterone supplementation. But we use that dose because a lot of it is because that was the dose that we were using in fertility treatments. So it had already been proven with many studies by Dr. Hilgers and his group that was effective, and we never want to give somebody more medicine than they need.
Okay, so there are side effects if you give too much.
If you give too much, there are side effects, yes.
Okay. Thank you.
Yes.
You had mentioned that chemical abortion and surgical abortion are almost even now. How many, are there any statistics about people having more than one chemical abortion? Considering, I saw the movie, what happens if you describe it?
Yeah, so the question was, what are the statistics of people having, essentially almost like using chemical abortion as birth control? That's kind of what you're asking. I don't know those exact numbers. I mean, it's rising because of the availability, the quick availability of the abortion pill. Now, of course, it still costs about $300 for a chemical abortion. Anywhere from $300 to $600 is what they charge. So that depends on how far along you are. But, and then the backup abortion after that. I don't know the number of repeat abortions, though, with medical abortion. I can certainly find that number out for you. Yeah.
But you said that the success at the failed abortion rate for RE46, is significant.
Yeah, so the failed abortion rate, if they just take one pill, is anywhere from around 40 to 60% failed abortion. If they only take an abortion pill, if they don't take the labor-inducing pill. But if they take the labor-inducing pill after they take the abortion pill, we're talking about a 98% effectiveness rate. only about 2%. And I do know, I certainly have heard of stories where women have had babies after taking just the first pill and not the second one. And I've even heard of situations where a woman took the first and second pill and still remained pregnant and had the baby. Those are very rare. Yes, sir.
What is the rate of women who are going to regular doctors for these pills as opposed to abortion clinics?
So the question is how many people are getting RE46 or the abortion pill from just regular doctors? Yeah, and if they are, it's not FDA approved because they're supposed to have certification to be able to prescribe those and also to be able to follow up for any complications. But there are even cases of internet abortion pills where people are just buying it over the internet from other countries. And then there's also cases where people have what's called Tele Abortions. So people in Alaska or people who are way out and don't have abortion clinics close by to them will have an interview on a television, on a computer with an abortionist who then pushes a button if the patient qualifies and a drawer opens up and they take the abortion pill out. Obviously, we don't like that because it's an abortion, but it's also extremely dangerous because we know that women after abortion, even taking a medical abortion, can bleed and bleed and bleed. And so that's one reason why we really fight against these tele-abortions, because they're terribly unsafe for women because they can be in the middle of nowhere and bleed to death and not be able to get to a hospital. Whereas if they're taking the abortion pill in Charlotte, at least there are hospitals around where somebody can do something if they bleed to death. But I don't know if there are any statistics out there about how many people are getting it from a non-abortion doctor. Certainly OBGYNs are probably doing it, that are not abortionists per se, but are OBGYNs.
I came across an article in the New England Journal of Medicine, April 17, 2019, where they were encouraging it to go in that direction. The conclusion is it's time for this to go to primary practitioners.
Right.
And I thought that was kind of scary.
Yeah, and Virginia just passed a law saying that you don't have to be a doctor. So essentially mid-levels are now nurse practitioners and physician assistants can essentially practice under their own license and provide abortions in states like Virginia. Yes, Father?
So if the randomized trials aren't really, possible for the treatment on fetuses and pregnant women, what's then the path towards a new treatment gaining widespread acceptance?
Yeah, so a lot of it still has to be retrospective studies and results. So essentially the question that he's asking is, and this is a question we get from opponents, is you need a large randomized placebo-controlled study, meaning that kind of what I described earlier, in their terms, you'd have to have a bunch of women impregnated, give them all RU46, give half of them placebo and half of them progesterone and see how many babies live. Obviously, that's completely unethical, and no one would go for that. And so we see this in cancer treatments. So a lot of times in cancer treatments, because people are in a desperate situation and all they have left is no treatment, death, or this experimental treatment that you're doing, this is how they do with cancer treatment patients. But they typically will not just give them a straight placebo saline infusion rather than the chemotherapy drug. You see what I mean? Because that would be unethical to tell someone, you're in a study, you might be getting the good medicine, you might not. Usually in those studies, what they'll do is they'll have an established treatment, and then they'll give them a new treatment. And so they'll give, people will agree to be in a cancer treatment, and they'll say, okay, I'm going to get a treatment, I just don't know whether I'm going to get the established one that is 70% effective, or I might get the new one with hopes that it's going to be 85% effective. Okay? And so that's how you do those type of studies. And that's the type of study we could do with this. So we already knew that 200 milligrams of IM progesterone was effective. Okay? We're getting about 50% effectiveness rate. But then we noticed that some women didn't want to take shots and they only wanted to take pills. And so we had random doctors that were just prescribing on their own, not following our protocol. They were prescribing 400 milligrams of progesterone twice a day. And then, lo and behold, when we get enough of that information in, we see that there's 68% effectiveness of survival of healthy babies being born with that. And so now we can say, oh, well, now we have more information and more protocols that we could essentially tell people, yes, well, we could give you one of these 3 treatments. We know that they're all effective, but we don't know exactly which one is most effective. And that's an ethical way of doing that. Now, to do that, you have to have an ethical review board, usually associated with an investigating university. And we used UC Davis for one of our ethical review boards. And now I could use Campbell University, where I'm an assistant professor at, to do that as well. And they're interested in serving as a review board for those studies. So it's possible, it's just very difficult. And also realize it's not like we have 1,000 women a week coming to us to reverse their abortions. So this is over many years, and it's a very slow process, but it's collecting data, which is also difficult in a population that generally switches their cell phone about every 2 months. They're very mobile, they're transient, they're getting kicked out of their houses. They usually are going for an abortion because they don't have the social support that they need. And so once they keep their baby, then they really don't have the social support they need. They don't have a stable home life. So it's very difficult to get follow-up on a lot of these. It's a very challenging research field. Yes?
In the movie Unplanned, I've had, we're discussing that with the other side. They said that Abby's medical abortion was sensationalized. It was pretty graphic. There was a lot of blood. I just want what you think. Was that made a little more like that for the movie, or could it be that bad?
No, it absolutely could be that bad.
Okay.
And I know Abby Johnson, and I've talked with her about that, and no, it can be that bad.
Wow.
Yeah.
Thank you.
Yeah, so it absolutely can be that bad. And it can be worse, because yes, women do die from hemorrhaging from these types of abortions. I'm not saying that every one of them, we might be talking about, 5% maybe are as bad as hers. 95% of them maybe are like a very heavy period, especially if you take the abortion pill when you're 6.5 weeks pregnant. But certainly the further along you are, and the bigger the placenta is, the more likely you're going to have more and more bleeding.
How much typically does it cost for someone to do the abortion?
Good question. So we figured it up with the injectable progesterone, and we're not talking about doctor's visits. We're talking about the medicine. It was somewhere around $250 to $300 for the reversal. And that's if you go all the way through the first trimester. Now, if you're using pills, it's probably $50. And if you're just getting those first 3 days in, which are the most important days, then you're probably talking about $10 or $15, honestly. So, and that's part of one of the research things that we love to see. We don't want women to go through pain of injections. We don't want them to have to do this for, a month and a half or 2 months. We'd love for women to be able to take 1 or 2 or 3 pills for 3 days and be done with it. And that's something that, research could figure out if you could set that up in an ethical way. And actually, we're starting to come something called the Steno Institute with Dr. Delgado, and that is going to be a pro-life medical research institute where pro-life doctors are going to kind of put their noggins together and see what we can do to figure out other pro-life strategies in combating a lot of the medicine that we have. Yes?
Can you explain to them with some of the moms that go to start the reversal and then they go on to their regular OBGYN, a lot of the OBGYNs don't know the protocol and follow up, so they would need to know how to tell the moms, instruct your doctor on how to do this reversal.
Yeah, so the question was, what do we do about the OBGYNs that don't know about the protocol? And a lot of them are really, will put it down. I will say that in OBGYN training, they did not train people in progesterone supplementation. That was almost seen like some type of fruity, herbal, root chewing type of naturopathic medicine or something. And you were looked down on if you thought that that would work. But the problem is that there's tons of research out there, and more people, especially people that are understanding natural medicine and really herbal remedies and natural progesterone therapy, are seeing that it really does work. And so that's one reason why we are very pretty adamant about wanting to give those first 3 days of treatment. Because if we can get those first 3 days in, I think we have a really good chance, even if they don't take any more treatments, of combating the abortion bill. But yes, so we have a website that people can get the information from the website. There's a phone number for providers to call to get the protocols directly from our administrators. And then if they are willing to, they can agree to share their data. Of course, it's all confidential with the patient, but share their data with us so we can see which protocols work the best. But we really need more providers that know this protocol. Yes.
So on tandem on that, what about having like physician assistants, nurse practitioners being trained to be able to give this regime, maybe even being able to be mobile to get to people, in case there's problems of being even able to get to the right facility for the progesterone. I mean, it seems like it could be fairly easily administered under a doctor's supervision.
Yeah, so we already do that. So I have a nurse that is, Courtney, who is on that picture, is a nurse. And just like a nurse in your brick and mortar office, I can call there and ask her to give a particular patient a medication, and she can do that, and it's perfectly legal and supported by the North Carolina Board of Medicine and the nursing administrators and all those folks. So in North Carolina, a mid-level provider, a nurse practitioner, or a physician assistant must work under the supervision of a physician. So that can happen too. And so if there's a nurse practitioner in the office or on the mobile unit, then they could administer the protocol as well, just so long as they have a supervising physician. That doesn't have to be on site. It doesn't have to be right there.
So that is being done?
Mm-hmm. Yeah.
Okay.
Yep. Yes?
What are the possibilities of being able to offer these progesterone pill-or treatment for anybody that might not have quick access to the provider?
Yeah, so I actually got a Facebook message from a woman in Argentina, and she had gotten the abortion pill just from a pharmacy there. And she took it, and she regretted it, and she looked up my information and found me on Facebook. And so I gave her the instructions on Facebook Messenger to go to the pharmacy, and gave her the recipe of how much progesterone to give, and her baby was fine. Yeah, so just so long as we can talk to them. In a lot of other countries, the medical laws are more lax, and so they have access to medicine a lot easier than we do in some places. Even if it's a very poor country, sometimes they can go to a pharmacy and just pick it up. That doesn't always mean their medicine is actually what they think they're getting, because also they don't have the FDA, they don't have the regulations that we do, so they might get something that's half as strong. But yes.
So do you also have the protocol in other languages? Would you expect that?
They do have it in Spanish. I don't know what other languages they have it in, but it's a good question. Yes.
Someone mentioned to me that here, that someone could go into the pharmacy and buy something over the counter that's an affordable.
Now you might be talking about Plan B.
Okay.
So Plan B is over the counter, and that's essentially it's like taking 3 birth control pills. So Plan B is what they call emergency contraception, is taken like the day after what they describe as unprotected sex. And the idea behind it is that it drops a big load of hormones into a woman's body to help prevent ovulation. But just like regular birth control pills, it can also, they're also abortifacient. And so contraception pills work in 3 different ways. The main way is by preventing ovulation. But if a woman is already ovulated and has intercourse, then the hormones in the birth control pills, especially in Plan B, which is a strong dose of that, they can change the mucus in the lining of the uterus so that sperm don't have nice straight channels to swim up to where the fallopian tubes are and to fertilize the egg. And it also will cause that cervical mucus to be a hostile environment for if there is conception that occurs between the sperm and the egg, then instead of that developing embryo implanting in the uterus, it will just come out like a menstrual cycle. So if you look at the hormone preparations for birth control, on any of the package inserts, it'll tell you those 3 different ways that they work. But Plan B is a high dose of that. And that's why people used to always say, oh, well, if I had unprotected sex, I'm just going to take 3 extra birth control pills. That's essentially what Plan B is. Yes?
Is there any way to bring this protocol to college campuses where the Article 46 is going to be in that circle?
Yeah, so good question. Can it be brought to college campuses? Funny you should say that because we're getting ready to open a new pregnancy center at UNCC. So that's going to be a place where students can go. It's right beside campus. They can they'll be able to get STD checking, but also information on contraceptives, about the dangers of contraceptives, and also about helping them with prenatal care and ultrasounds for moms and kind of fighting the industry of abortion. So we know in California they're passing laws saying that colleges would have to provide, and often free, abortion pills because they're on college campuses. And we all know that college kids just have no self-control. And so yeah, it's going to be hard to convince them to do that, but that's definitely a place where we see a need arising because the abortion pill industry and use is just climbing and climbing. Okay, well, I'll hang around if y'all have any more questions. Thank you very much for your attention.